I would like to thank you all, and I thank Dr. Maher and the organizer for inviting me to be here today. And I'm actually delighted to be in Egypt's line. Can I have the first slide, please? Basically, what we are trying to do today, I'm not going to repeat what has been done about the testing, but when we talk about desensitization of a patient, we need to know how to test for this patient in order to desensitize it, not to transplant. So there's a little bit difference between when we type a patient for transplant and when we select a patient to be desensitized, on what basis we should. So if we take the registry in Yunus, we nearly had about 30% of the patients who are in the waiting list are non-transplantable, and this is basically because they have a very high active antibody index. And the origin of the antibodies, especially when we're talking about desensitization, I like to insist to highlight the blood transfusion. And the blood transfusion here we divided into two. One is that is directed, which was in the old era of using a donor-specific transfusion to improve the transplant. But while we're doing this, we have also induced a donor-specific antibody to some of these patients. And we have what we call the random, which is a medical need, which is not directed. So this is used from different type of people. We talk about the pregnancy, and unfortunately, pregnancy is a very serious effect on desensitization. I'm not just, all this is to reach the desensitization. And you can say that we have antibodies against major histocompatibility and the ones about the minor histocompatibility. Now, I'm not going to talk about, in this case, we can classify the antibodies as private. We look at the public, which is the gray, and we look at the multi-specificity, and that will become important for desensitization. We can look at the pan-reactive antibody, we can look at the donor-specific antibody and the cross-matching. When we do an endpoint of antibody detection, we look to see if we have an HLA versus non-HLA. We want to look at the specificity of the class 1 versus class 2, and we look at if the antibody is IgG or IgM, and we listen today if we have a CDC positive. And this is very important. CDC cross-match is a very important area. And Dr. Khashab just indicated that we have about 5 to 6% difference between the CDC and the flow cytometry. That's true, because we still have rejection, because that 5% which is detected by the flow cytometry are those non-complement dependent rejection. And this is very important. We need the flow cytometry to get these patients. And when we look at the flow cytometry, this is a negative cross-match. And we look at, so I don't know if this works. This is class 1 and the class 2. You can see the positive, you can see the negative, and you can see the patient. And this is a positive flow cytometry cross-match, and you can see that the patient in the blue becomes positive. This is the shift. And what's important here, if you have your patient is a life-related donor or non-related donor, you can follow him up. And you can do using the donor, and you can see the flow. If it is changing, it's still negative, post-transplantation. So the flow cytometry is not only important to pre-select the patient, but also to follow up the patient. You can still do the flow cytometry. We also find that we have a selected group of patients that would not be defined by flow cytometry or by the CDC or even by pneumatics. So what we do, we take the cells and we elute the antibodies from the cells and we incubate it with the cell of the patient, and then we add a dye and we detect. This is a very sensitive assay, but unfortunately, if you are not expert in it, you may denature the proteins and you may have a false positives. With the donor-specific cross-match is that we do detect the soluble antibodies, and this is very easy to do if you have, but sometimes as I said, this is the problem. A positive cross-match resulting from a confirmed HLA antibody is a great clinical value. If we do not define it, it becomes a questionable, and some people do not like it, some people do, and I'm not going through the controversy about the non-HLA antibody, the autoantibody, and the B-cell active antibodies. Now, the concept of looking at a patient on transplant Suppose we take a patient and we consider a non-sensitized patient and we don't do the cross-match, and we think that if we do the PRA without going through the cross-match, and we say he's a PRA negative, let's do a transplant. And that's actually a dangerous act. And many of the centers who tried to do that, they went into the fold that without the cross-match, you should not transplant the patient. You do not just depend on the PRA to transplant your patient. Now, okay. The idea of donor-specific antibody versus the panel-reactive antibody. If you have a low donor-specific antibody with a low PRA, especially with a zero donor or donor, you have an easy for desensitization or for a curve exchange. This is some of the theories that we practice in our own center. If we have a high DSA with a low PRA, especially in this case, is the DST is an example because we did a study to do DST, and unfortunately we have sensitized many of our patients with that, and we have a very high difficulty to do sensitization. If we have a low DSA and a high PRA, we can do a per donor donation, and we can do sensitization. If we have both high donor specific and high PRA, it's difficult to do both. So the idea of desensitization is to remove or neutralize the IgG, or prevent the formation of a new anti-IgG before transplantation. This is very important. Is just by removing the antibody by itself, you do not solve the problem because these antibodies will come later on. Transplant, when a cross-match is negative, prevent the formation of a new anti-IgG after transplantation, and to rapidly diagnose the acute rejection. What we can do with desensitization? We started with statin. We have plasmapheresis, IVIG, immunoabsorption, anti-CD20, protoximab, complement inhibitors, and actually many centers do splenectomy, and we can do nothing. We have done a study with the statins. The statins, unfortunately, we didn't do a controlled study, but we started with 20 milligram giving the patient for approximately 4 months before transplantation, and we went up to 40 milligram, but it was done to see if the liver function is good, then we can increase the dose. You cannot give it to patients who have a problem with their liver function. So we have 10 patients who underwent successful kidney transplantation. None of the patients developed hyperacute rejection, and there was no graft loss during the first 2 years of post-transplantation. 4 patients lost their graft, and 6 are still doing well. 14 patients stayed on, and unfortunately, those patients have a very high PRA level, and we were resistant to desensitization using different. In Turkey, they did also a non-controlled study, and 30 patients were enrolled. 10 of the 30 were transplanted, no graft loss. 30 patients remained on dialysis with positive PRA level. Those who were transplanted had negative also flow cytometry cross-match. So even when you desensitize, you still have to do the cross-match. Make sure that your patient is negative before you transplant. The only randomized proper controlled study was done in Shiraz, and they have 164 patients, 82 with control, and 82 received placebo, and they also have a very good result with the status. Now, plasmapheresis, when I was doing my intern, we were using the plasmapheresis for autoimmune diseases. So it was very easy for us, especially for lupus, and we were doing the plasmapheresis, and we thought that if we can extend that to the PRA to remove the antibodies with the plasmapheresis, it would be a good idea. Unfortunately, it's not very specific, but it is the easiest to perform. So if you do plasmapheresis, you may have success in only a small percentage of your patients. Immunoabsorption is another technique. It's similar to the plasmapheresis, but instead of doing a plasma exchange, we add a column. This column has a protein binding where it can bind specifically to the IgG and remove it from the circulation. So it is much more efficient than the plasmapheresis. It is more specific to the antibody, and it gives a window of opportunity, but it does not prevent the antibody from coming back again. So it gives you only a window where you can transplant without hyperacute rejection, but you have to do still the induction and immunosuppression. So a study that was performed in 1996 in King College in London, they have do with the immunoabsorption transplant, but 70% are acute rejection and 53 graft survival at the last follow-up. It's about 4 years. In 1990 to 2003, the Vienna group have a 73% survival rate, and they have 20% cellular acute rejection and 33% human rejection. Even when you desensitize your patient, you are not preventing the rejection to happen, but at least you will be able to. And now, a combination of the IVIGG with plasmapheresis, some of the current protocols are modification of the high-dose intravenous IG and plasmapheresis alone or in combination. So we can put the two together. The IgG is pulled from multiple donors, block the FC receptor on molecular phagocytes, and anti-nucleotide effect, and inhibits the CD19 expression on activated B cells. It also inhibits alloreactive T cells. Now, and this Stegel and Ita have divided their patient into 3 groups, received high doses of IVIG, received plasmapheresis with low dose, and rituximab, and the third group received plasmapheresis, low dose, and the pre-transplant anti-lymphocyte globulin. So you can see the combination is very big, and the expense is very high. But the results that in the first group, in the high dose, they have 38% patient achieved a negative cross-match, 84 and 88% of group 2 and group 3. So the heavier the desensitization protocol, the better the result. The acute rate was 80%. Now, anti-CD20 has been approved for treatment, actually for lymphomas, and we have now started using it at the dose of 370 milligram per meter square for using as the desensitization. We have done 5 patients only we have treated, all had their PRA level determined pre and post-transplant, about 50, all had their CD20 count were determined. I'm just putting the table to tell you one of the patients. We started with 236 CD20s, and you can see after nearly 2 months of treatment, he had 8. So it's definitely, we have really depressed his immune system, and it took nearly 6 months to even to start coming up. So by doing that, we may able to transplant the patient, but we are not talking about the side effect because the patient have prone to opportunistic infection, and 3 of them developed very severe CMV infection. Now, combining both rituximab and high dose of IgG reduces the total dose of the IgG. And if you start looking at the PRA levels and you see how the transplantation, and not only that the desensitization protocol is very heavy, but also the immunosuppression post-transplantation is heavy. So the PRA goes down from 40% to from 77 to 44, 16 out of 20 transplanted. Mean time to transplant is about 6 months. The acute rejection is still very high. Also, we have the proteasomab. It's a proteasomal inhibitor, and it has been given 1.3 milligrams per meter square. And there are some complement inhibitors that has been used, and it's also those were not the approval not for this, but they have been approval for cancer treatment. Other centers selected to do splenectomy. Splenectomy has been successful. Unfortunately, it's a very, I call it a draconian exercise because also you have left your patient without a good immune system. And the Mayo Clinic protocol uses splenectomy with hypoglobulin, and they have 14 patients who done this, and to living donors, and acute rejection is 29%, but for reversal. So you can do it, but also we do not know the side effect of this. The Eurotransplant has an algorithmic for the highly sensitized patient, and this algorithm divided into 2 parts. One is made for the deceased donor, and one is made for the living donor. And both of them, they can divide them into 2, You have to have, even after you desensitize them with the plasmapheresis and with the plasma exchange and even with the IVIG or with the CD20, you can, if they become negative cross-match, you can transplant them, and if they not, you will not be transplanted. The same thing can happen for the living donor, and in both protocols nearly similar. Europe can use the plasmapheresis with the anti-CD20. They don't depend so much on the IVIG compared to the Americans who like it. The other one, if we look at the switch protocol, they use the CD20, they use the tacrolimus, and they use also the absorption pre and post transplantation. But also when they do this transplantation, they have to say that it is the cross-match is negative and the 3-year outcome is similar. The other alternative, I don't think none of the centers in the Middle East are using this, but there is now a group that will start it as a method trial. This will include Turkey, will include Saudi Arabia, and will include Lebanon. And this is to see if we can do for desensitized patient, instead of desensitize them because of a donor-specific antibody, go for a third kidney exchange, where you select the patient, the donor, who does not have HLA, to which the patient is sensitized, and you do the pairing system. We don't know if we are going to be successful in that, but we still, in many cases, we can go for the desensitization, and if we fail, we go for the pairing program. So we can do that, the highly sensitized patient, if we do not have a live donor available, desensitization, high doses IVIG, wait for cross-match and transplant. We can go a compatible living donor. We can for exchange between them, desensitize. If we cannot desensitize them, then we can do for the program. In conclusion, we can say that the sensitized patients are at transplant risk. It is contributed to a very increase in the waiting list. We have in our center approximately 1,800 patients who are waiting. They have their serum stored historical, and we require to have a serum every 6 months. And we have at least 35% of them non-transplantable because of that. We still believe that statin is the cheapest way. Plasmapheresis with IVG is very highly in mode in the state, and you can do immune absorption with IVIG. You can use anti-CD20 and others. But I tell you, for the 5 patients who we desensitized with anti-CD20, the cost was $800,000. So it's very highly expensive, and it's not as simple as we think. Thank you very much.
Thank you, Professor Marwan, for this excellent presentation. I think we have 1 minute for more questions.
May I ask a question to Professor Marwan? These desensitization protocols are very expensive.
Yes.
If we 4 are waiting for a kidney and all of us are highly sensitized, how can you be sure that one of us is going to get the kidney unless you are dealing with living donors, living related donors? If you are dealing with cadaveric donors, انا هعمل desensitization وصل 800,000 دولار وما جاليش كده في شهرين 3 كل الانتيبوديز رجعت تاني. يعني it has to be, you have to have the donor in your hand, and then you desensitize the patient and then give him the kidney. And this is not possible because the desensitization protocol takes weeks. In cadaver, يعني ازاي بانتيسيبيت ان انا اعمل desensitization عشان اخد كادافير الكدني لو انا مش عارفني كما تجيليش.
Okay. Can I?
Yes, please. انا مستفسر بس.
Okay. Basically, most of the patients that we desensitize are usually waiting for the renewal. Okay. The second group is we desensitize. There is a protocol to desensitize any patient who is above 50. So we think that anybody who's a high titer is ready for desensitization, even if an awakening person. So desensitization protocol in the state is covered by the insurance company. So it's actually the patient does not pay from his pocket. But in Lebanon, I tell you, the only thing that was able to do that is the army paid. If we have the Ministry of Health paid, we would not be able to desensitize anybody using these tools.
How can you be sure that I'm going
No, these were not, those were, in Lebanon, those were for living donors, not